Welcome all. We're just going to take a minute or two for everybody to join. So I guess we can start, and I'll hand over to Alan Saget and to Marco to get this meeting going. Thank you.
Thanks, Mari. Good morning, good afternoon, everyone. Welcome to this meeting, which is called Stakeholders Update Meeting on the clinical trial on the MAMI to generate strong evidence to guide the scale up of the management of mothers at risk and just infants below 6 months. This meeting is prepared with a strong conviction of stakeholders engagement is really important, not only for the smooth implementation of the clinical trial, but also to ensure the proper uptake of the findings for and scale up in different countries. So we have guests and participants from different institutions and countries. So please send your details, your name, your institution, and association with MAMI program. So we appreciate that kind of information to generate a report which can be used for the dissemination. Thanks for joining us. So we have a series of presentations on the clinical trial update and other findings from different studies conducted in relation to CMAMI. Thanks all for joining us. Thanks, Mari. Maybe Marco can adapt. Thank you.
Great. Thank you all very much. So I want to say a big thank you to everybody for joining again today. So my name is Marco. I'm the overall chief investigator for the project, and it's a real delight and pleasure to be working with colleagues, partners and friends at Jimma University, Goal and Emergency Nutrition Network, and also wider partners. Like, great to welcome Rosie Coper from the SDG2 Alliance today. So you'll be hearing more from her. So again, just to say a big thanks. And this is a follow-on to a meeting that we had in October last year when we were launching the project. And it was great to get people's feedback, people's perspectives, people's input in the early phase. And what this is about is updating you what we have done the past year. So even with COVID, we have had lots of things going on. So particular thanks to wonderful Ethiopia team who've kept the show on the road in very difficult circumstances. So there's lots that has happened, and we're now at the stage of planning the randomized trial for which we hope will start mid-2021. So this is an update on that, and really a chance to talk about the plans, a chance to get some feedback here from a slightly wider group about what you think might be the opportunities and how it might help your organizations, and also any particular issues or challenges or problems that you might foresee that are good for us to be aware of. So really appreciate your taking time to be here. It's the end of year. We see that, you know, numbers are trimming off because people are feeling very, very zoomed out. So there's a pandemic of coronavirus, also a big proliferation of Zoom, and that's creating other challenges. So great that you can join, and look forward to hearing your perspectives today. So just to share, I think everybody should be able to see the timetable. And just a reminder for everybody, please just do introduce yourselves on the chat box. So we haven't got time to go through with individual introductions, but then we'll launch into some feedback, dissemination of the work that's been done over the past few months. And then we'll have a short break in coffee rooms, trying to replicate the normal coffee line experience, just get to hear some perspectives, get to know each other a bit better. And then we'll have time after coffee to discuss in a bit more detail about what the what's going to happen for next year. And that's a chance to discuss. And we'll do that just as one group, and to let us know how we can make things as successful as possible. So with that, I'll hand over to Marie. And again, thank you all for joining. Great to see you today.
Thank you, Marco. And I'm just going to get my slides up. Larry, you're sharing my presentation, yes?
You're doing the recorded version, are you, Marie?
I am. My internet is very troublesome here in Oxford.
Okay.
So we're gonna.
You're gonna mime along then. Well,
I will. As I'm turning my video off, because people say, "How is she doing this without moving her mouth?"
My name is Marie McGrath, one of the technical directors at the Emergency Nutrition Network and part of this research partnership that we will share with you today. I'm going to begin with a brief overview of some of the headlines coming from 10 years of effort on the management of at-risk mothers and infants under 6 months of age, or MAMI. What is MAMI? Why it is important, where we are heading, and how we are building critical evidence in Ethiopia together. What I will share with you today reflects the thinking, dedication and drive of an informal network of researchers, practitioners and experts coordinated by ENN and co-led by ENN and LSHTM. The MAMI Special Interest Group was formed in 2010 following a 2-year ENN research project that identified critical gaps in policy, research and programming. Currently, it is an informal network of around 71 researchers, practitioners and experts committed to harmonise effort, collaborate, share and learn. So what is MAMI? MAMI focuses on small and nutritionally at-risk infants under 6 months of age. Mothers and infants come as a package. The well-being of an infant is intimately tied with that of his or her mother. Babies that are born small or who are nutritionally at risk, such as wasted, stunted, underweight, failing growth, are at increased risk of death, of later malnutrition, of poor development, and long-term health problems. And there are lots of them. We estimate that 8.5 million infants under 6 months of age are wasted in the world. And as I say, it is not just infants who are wasted that are at risk. Infants who are underweight, stunted and born small have increased risk of death, poor development and long-term poor outcomes. Helping small and nutritionally at-risk infants under 6 months to grow well is a critical part of the life cycle approach. Making sure mothers are nourished and healthy before, during and beyond pregnancy is essential to safeguarding all children. Our reviews and research and capture of experiences worldwide found that support in the first 6 months of life was a greatly neglected part of the life cycle approach. Small babies grow into small mothers who have small babies. We need to break this intergenerational cycle of malnutrition. We urgently need to fill the care gap that currently exists for infants up to 6 months of age. We need to act globally. Helping small and nutritionally at-risk infants under 6 months is critical to our achieving the Sustainable Development Goals. So how can we make this happen? Our vision is that at every infant under 6 months, at every community or health service contact is nutritionally assessed and appropriately supported to survive and thrive. We are updating the vision and mission for both the MAMI approach and the MAMI Global Network. Towards the close of this meeting, I will share some of the options we are looking at to get your gut reactions. In MAMI, we want to ensure a continuous pathway of care that identifies, assesses and supports infants who are small and nutritionally at risk. So what does this look like in practice? We have detailed an integrated pathway of care that works with and within the system and services and particular needs of mothers and infants. It consists of community screening, outpatient assessment and care, and referral to relevant services. Unlike community-based management of acute malnutrition for older children, there's not a specific programmatic model to follow. What a pathway of care looks like depends very much on the context. We will test this integrated pathway of care in the randomized controlled trial in Ethiopia. The MAMI approach is about making stronger links with antenatal services to ensure continuity of care between postnatal care and community follow-up, especially of babies who are born too small. For example, it is about making the most of opportunities when we have contact with mothers, such as during antenatal visits and immunisation visits. It is about making the most of every health centre contact a mother and infant has in the first 6 months of life, when they are well, like in growth monitoring programmes, and when they are sick and present to a health post or health centre. The MAMI approach links prevention and treatment. If you take a public health lens, primary prevention prevents disease. Secondary prevention deals with early problems to prevent decline to something more serious, while tertiary interventions prevent serious negative impact on health. The MAMI approach straddles primary and tertiary prevention. On the nutrition front, it dovetails with infant and young child feeding interventions that operate more at the primary level of intervention. So really, it is all about different levels of prevention. The MAMI approach is also all about building the right relationships between health services, mental health services, social services, nutrition programs, and beyond. From an individual level, between mothers and infants, within families and within communities, to multiple services. The MAMI approach is all about building bridges between infants, mothers, families, and societies, in the community, from community services and community health workers. It links anthropometric assessment and functional outcomes. It links nutrition with health and disability. It links national and international agendas and actors. And it bridges humanitarian and development contexts. So where have we got to over 10 years of working together as a MAMI special interest group in this area? We have seen good progress. Infants under 6 months are no longer a blind spot as they were back in 2008. We have seen significant shift in policy, with the WHO wasting treatment guidance update in 2013, recommending community-based management of wasted infants under 6 months of age for the first time. MAMI programming is being implemented in small-scale NGO-led pilots in several countries, led by Save the Children and Goal, including in Ethiopia. Several NGOs have also undertaken operational research, again including here in Ethiopia, that has really helped inform programming, tool development, and pose further critical research questions. But we are not there yet. Scaled-up care of at-risk infants under 6 months who need support needs to include community-based management of small and at-risk infants. Community-based management revolutionised the treatment of wasting in children over 6 months, but inpatient care still dominates management of infants under 6 months of age. A review we recently completed of 71 national and international guidelines on wasting treatment found only 5 included community-based management for infants. Most, including Ethiopia, still rely all on inpatient care that is more costly for health systems and families and is often not the best place for the support of these infants. We learned that governments are demanding more robust evidence before they change policy. They very reasonably want to know what interventions work and how in different contexts. How are they integrated within existing systems and services? There may be complex underlying pathology. How do we manage these? What are the implications for cost and capacity? And is what we are proposing scalable and sustainable? The need to answer these critical questions is what has prompted us to scale up our MAMI Special Interest Group into a MAMI Global Network. We want to co-create and co-deliver robust, relevant research that is driven by country agendas that informs national and global policy development. We want to do even more together to galvanise and support collective, collaborative, harmonised efforts on research and policy to inform best practice that is scalable and sustainable. We've been part of a MAMI evolution over the last 10 years. We want to bring about a MAMI revolution. This is why we have turned to you in Ethiopia to lead the way. I'll now hand over to Malcolm and the team to update you on MAMI research that we are undertaking together in Ethiopia to help fill critical national and international evidence gaps. Thank you.
Thank you, Mary, for your nice presentation. And now we will be having series of presentations. We will have around 4 presentations to be presented by our colleagues in Jimma University and from London School of Hygiene and Tropical Medicine on with regard to what we have been doing the last 1 year and with regard to what we are planning to do subsequently. So each presenter will have around 10 minutes, and first presenter will be Nagajibat from Jimma University. He is a qualitative researcher, and he's going to present findings from our qualitative research we have carried out in Jimma Zone and Deder district of East Hararge Zone in Ethiopia.
The presentation is on carers and health workers' perspectives on malnutrition in infants under 6 months. I'm Nagajibat from Jimma University. This study was conducted in Jimma Zone and Deder Woreda in Oromia. Comparatively, Jimma Zone is categorized as food secured area by government, but there are emerging evidence that challenges this decision. Like some Jukan studies have discovered a significant caseload of malnutrition in the zone. Whereas Deder Woreda is categorized as food emergency support area with a dilemma of high chat production. This formative qualitative study is mainly intended to inform the RCT on the management of nutritionally at risk in small infants under 6 months. Specifically, the study is intended to understand the perceptions of carers on the health and well-being of infants under 6 months, exploring feeding practices, how malnutrition in infants under 6 months is viewed and detected. The study is purely qualitative with 31 key informant and in-depth interviews with thematic analysis. It was ethically approved and the application is ethically sound. 14 mothers and fathers as carers participated in in-depth interviews, whereas 17 health development armies, health extension workers, healthcare workers, district and zone health office MCH coordinators participated in this study as key informant interviews. Generally, 21 participants from Jimma and 10 from Deder have participated in this study. To understand the perceptions of carers on the well-being of infants under 6 months, we emphasized on their characterization of ideal infants. Accordingly, they primarily rely on the behavioral manifestations and physical growth and appearance of their infants to define the health and wellness of their infants. Hence, infants who properly and frequently feed, who do not persistently cry, who regularly sleeps for long hours but not excessively long, who are burping after feeding, and those who have a smiling face and emotionally engaged with people around them, and infants whose size increase along time, and those who are fat and physically attractive are largely considered as ideal infants. In the second level, there are some carers who also consider maternal conditions like whether they have received proper care and support during pregnancy, the delivery was institutional, whether they had proper feeding and in a good health, and finally whether those infants enjoy antenatal care, postnatal care process during pregnancy, and those who have access to exclusive breastfeeding and vaccination after delivery are considered ideal infant. So except the technical details given by healthcare workers, content-wise, the idea, the perception of their cares are similar with that of healthcare workers with regard to defining the ideal infant. Healthcare workers strongly promote exclusive breastfeeding, and exclusive breastfeeding are the only and the most desired feeding practice among carers. Unless there are some exceptional cases, they have similar awareness with strong values, and they also make efforts to make it really happen. Coming to the carers, they have good awareness, but with mixed perceptions, with mostly in favor of exclusive breastfeeding, but there are also some challenging builds there, and there are also uneven practices, including among health workers as parents, with some degree of exaggeration. Everybody knows about exclusive breastfeeding, but not everybody practices. Additional feeding is introduced as early as of the first day for different reasons, and even those who claim practicing exclusive breastfeeding do not do that to the full range of 6 months. Therefore, exclusive breastfeeding is highly challenged by living conditions, particularly with the work nature of the woman, social values, and views under pressure because of consultations with the elders and neighbors, and also there are gaps in policy. Whereby short-term maternity leave is highly emphasized by employed mothers. Locally available food items are introduced in most cases, yet formula is emerging as a new practice among urban residents, people with better education and income. Maternal health and feeding practice is an integral part of under 6 months infants malnutrition, but it has not received proper attention so far. For health workers, increasing awareness and concern about this issue is reported, and for carers, they are well informed about this issue, but they are less seriously taken than exclusive breastfeeding. Health workers advise mothers to have variety and at least one more meal per day, whereas carers are very much reluctant due to cultural and economic reasons. Culturally, it is not acceptable for mothers, for women, to have different food from their husbands. Rather, they are expected to have food in the last order, as well as in a small amount. Economically, they cannot afford what is suggested as a variety of food. Health extension workers demonstrate how to prepare balanced diet composed of different food items, locally produced, whereas mothers sell those recommended food items to purchase cheaper food items from market like biscuits. So, workers witness poor mothers' health, physically, socially, and mentally, and they are very much worried about this one. And at the same time, many mothers with under 6 months malnourished infants are malnourished themselves. Failure to meet the expected behavioral and physical manifestations of an ideal infant is a general indicator of infant's health problem. Thinness, persistent crying with agitation, edema, and unable to suck are well considered indicators among carers. In principle, health workers more rely on standard measurements than physical indicators, but there are some practical gaps reported among the health workers. Potentially, MOAC is preferred and easier to use for under 6 infants, yet some health workers have fears about its diagnostic power compared to other measurements. Standard treatment is given at health centers and hospitals. Health extension workers identify and give counseling service for the carers. Carers' care-seeking behavior for under 6 months infants has improved. For example, there is positive response to referral order unless they are economically constrained. Currently, most carers prefer visiting health center by passing health posters because they know that there are no treatments for this age group at health posts, though they aspire to get the service at the nearest possible, at health post or at home. There are several treatment challenges identified in relation with carers. For example, there is a lack of tolerance among mothers to stay in the health facilities when their infants are admitted, and there are cases whereby mothers escaped from health facilities, from hospitals, from health centers, leaving their infants even in the health facilities. And at the same time, there is unwillingness by the carers to stop additional feedings, even under the supervision of the health workers in the hospital or health centers. Some health workers have low commitment and also inadequate training to give the proper services. With regard to supplies, there are many complaints, particularly from the health centers, lacking very essential elements, inputs for giving the service, and COVID-19 by itself came up with its own challenges for the treatment. There is growing and shared understanding between carers and health workers on matters of infant health. However, these and other improvements are accompanied by persistent challenges attributed to structural and behavioral problems. Delayed interventions, less attention, and limited successes are observed in improving maternal conditions, which have multifaceted negative implications to the infants, the mothers, the family, and the community at large. Therefore, policymakers, implementers, and users, including the community, should collaborate and actively engage in reducing the risk of infant malnutrition and that of mothers. Towards that end, involvement of men in the process, in the decision making, is not optional, given their influence on the lives of the mother and the family and the community at all. Thank you very much.
Thank you, Nagga, for your excellent presentation. Next presenter will be Carlos from London School of Hygiene and Tropical Medicine. He will be presenting findings from quantitative survey of infants under 6 months. You can start, Carlos.
Thank you very much. And thank you very much, everyone, for being here. What I'm going to be showing to you is basically just some preliminary results for the health center surveys that we have been undertaken primarily in Jimma Zone, and that is currently being undertaken in Deder Zone. But I want to put this in the perspective of the overall work that we're doing with this for this RCT. So for this RCT, we are undertaking secondary data analysis. You're going to be hearing about this shortly. We also engage into a health center assessment first to be able to understand all the health centers, the distance, the ease of access, etc. This survey that I am going to be presenting you some data, the qualitative study that Nega had just presented, all of these 4 elements are going to be fed ultimately into the RCT, which Marco will be talking to you shortly as well. So with that ado, I'm going to be moving forward. What we did, oops, my computer is not. The objectives of this health center survey was primarily to assess the anthropometric deficit prevalence and to understand how these different indicators of anthropometric deficit overlap. And in this overlapping, to try to ascertain and to understand the utility of simpler measurements for assessing being a small or being at risk infant. So we were wanting to understand how MUAC, or a way for age set score, might be able to capture all the more commonly described anthropometric deficit like stunting or wasting. And apologies, my PowerPoint seems to be moving on its own. And the last objective was to also try to assess infant feeding practices, building on some of the qualitative work that Nega just presented to you. So again, just to put it in perspective, for those of you who might not be familiar with the geography of Ethiopia, we are working in the Jimma Zone, which is marked in this slide in green, and in the Deder Woreda, which is marked in this slide in orange. We have 8 clinics in total in Deder region, and we have, well, many more in the Jimma Zone. So we have to do a selection sample in the Jimma Zone, and we are going exhaustive in the Deder Woreda. So first we did a health center assessment. Primarily we wanted to understand distance, ease of access, patient load, and also get to understand the health centers. And based on that, we rank all the different health centers using an approach that we are planning to use for the RCT to decide, okay, we have this pool of, in Gima, this pool of health centers that are on okay distance, they have sufficiently ease of access, and they have sufficient patient load. So from this pool, we randomly selected 10 health centers to be included in the survey in Gima. And as I mentioned before, we went exhaustive in Deder, although at present we're still collecting the data there. So we originally thought of collecting 3 weeks worth of data in each of the centers, but given that the patient load was a little bit bigger than originally expected, we ended up with just a 2-week collection period. So we have finished all the data collection in Gima. So I'm going to be presenting to you now the results from Gima. And unfortunately, the Deder one, we're still in the process. There have been some delays due to COVID, but we are moving. So at the moment, our colleagues from GOAL are collecting all the data in the 8 health centers in Deder. In Gima, we have managed to survey a total of 625 infants. And as I say, we are undergoing work on Deder. So here, what you see in the first graph is a distribution of the age of all of the infants that we have data from. And as you can see, I mean, this is the reflection of the patient caseload in the clinics. We have a very few infants that are between the ages of 1 month to kind of like 6 months. This is just how it is. I mean, it seems that between those particular ages, they are not coming to the clinic. And we see obviously what it appears to be an overrepresentation of 6 to 7. This is primarily because infants are coming into the clinic due to for vaccination purposes. So going straight into anthropometric failure, this is the prevalence and overlap of anthropometric failure. It's a little bit tricky to understand what presented in a table, so I'm going to be showing you this data in detail in a Venn diagram, but just suffice to say, this is what is called the composite index of anthropometric failure. We are seeing here different categories of anthropometric failure, and some of them overlapping, like, you are just wasted, you are just stunted, you are stunted and wasted. So we see these things kind of coming together. And what we see here is that we have a total of 614 infants. That is, we managed not to get the full complete data on the 625, so 98% of the sample. But in this, we see that anthropometric failure by CF is about 16%. So now moving on, what we're hearing here is the first part of the Venn diagram. It's just a circle. We're seeing how many stunted of these 614 infants. And what we have is that the stunted infants were about 46. That is about 7.5% of the population, ranging from between 6 to 10. This is the total of stunting that were coming into the clinic. Wasted were about 8.1%, or 50 infants. This was ranging between 6 to 11%. Then we have the underweight. The underweight is a simpler way of assessing undernutrition or malnutrition, of being small or being at risk. So we are just using here the weight for age. This is not often used and it's not recommended at present, but we are trying to generate the evidence that it might be in this particular group an important indicator. So what we're finding here is that proportion of those are 11.4%. Oops. And so that is broadly what it is underweight. And then we are using low MUAC. We're building on the work that GOAL has done in Ethiopia. So in this particular age group, we don't have a criteria for low MUAC. So we're using an experimental one, and I put it between brackets experimental, of using 11% as a cutoff value to say this child is of low MUAC. What we're finding in there is that about 14% of the children have low MUAC. So now let's start to try to kind of look at the overlap. And the first thing that we see is that there is overlap between wasting and stunting, but this overlap is not necessarily very big. It's about it's less than the 10% of the total children who are wasted or stunted would be concomitantly wasted and stunted. Now, when we look at the overlap with these other easier to use indicators, for instance, the underweight, we are seeing that underweight more or less, well, first, we see that, as I mentioned before, 16.5% of the population would be either underweight, stunted, or wasted. But what we are seeing here is that underweight is about catching up identifying about 64% of all of the infants who are wasted and stunted. So it's missing about 36%. But Underweight is capturing all of the infants that are wasted and stunted. So it seems like it's good at catching up with multiple anthropometric deficit, but it's only catching 64% of the infants that are wasted or stunted. Low MUAC, in the other hand, let me just do this change again. And I want you to pay attention to these particular numbers in here. Look how this gets small. So low MUAC seems to being able to identify less the number of children who are stunted or who are wasted. Now, with low MUAC, what we have is we are increasing the caseload of children who would be identified at risk or would be identified as small. We're increasing it from 16% to 22%. But one interesting thing is that the low MUAC is only being able to identify about 41% of all of the infants who are either stunted or wasting. So it's missing like 59% of those children. So you can see that the ability of low MUAC as an indicator at this early age seems lower than the wait for age indicator. So if we look at them all together, what we're finding is something quite interesting. First, what we're seeing is that there is not very strong overlap between underweight and low MUAC at this age in these clinics. So there is about a third overlap. So there is 2/3 of children who are either underweight or low MUAC that if you were just to use one of those indicators, they would not be being picked up. But interestingly, with regards to wasting and stunted, the majority of the children who are identified as wasted or stunted by underweight would be also, by low MUAC would be also identified by underweight, although we have a very few that might not. But more importantly, we have a large proportion of infants that will be categorized as low MUAC that are neither underweight, stunted, or wasting. Or wasted. So this is an interesting finding to see how these things overlap. Now there is an age element to this thing. So here, let me just complicate the picture, pixel it a little bit more. So what I'm doing is I'm taking all the sample and cutting it not in half, but I'm taking the first 2 months of life, so the very young, and then the less young. So from 2 months to almost less than 6 months. And what we're seeing is something interesting. First, we see that most of the children who are low MUAC, who are neither underweight, stunted, or wasted, are very young children. None of them are the older ones. So this seems to be low MUAC as a criteria seems to be affecting or identifying children differently according to their age. But interestingly, for older ages, for instance, the wait for age criteria, the underweight, really, captures all of the ones that would be either captured also by low MUAC. So there is none that are not captured by the low MUAC that were left out by underweight, whereas there are some when they are very young. So again, the overlap seems to be affected by age. So not wanting to pixelate too much, I'm going to stop it there with the anthropometric deficit, and I'm going to jump now into feeding practices. And what we were looking primarily was we were trying to ascertain the pattern of exclusive breastfeeding. And what we found here, the line that you see here is the disappearance of exclusive breastfeeding by age in this under 6 months. So it starts quite high. It starts at about 80%. Obviously, the recommendation is 100% throughout all this time. So anything above this line is children at risk. But what we are seeing is that from birth, it has a very sharp decline that by the age of almost 6 months, is about 10% of the children are still being exclusively breastfed. And what we're finding in here is that by the age of about 2 months or 8.7 weeks, half of the infants are no longer exclusively breastfed, which again is an indicator of risk, is an indicator of public health strategies in this particular region. Now, when we are seeing, okay, so what are the things that they are consuming? We start, here I'm plotting some of the culprits. It appears that the main culprit is water. So what we are seeing in here is this line is the emergence of water in the infant's, let's call it diet. The blue line is the emergence of other liquids, because there seems that in the area they tend to have like herbal teas. The green area, the green line is the emergence of milk. And then this solid red line is the appearance of bottle feeding. So the reporting that the child has been bottle fed, either by giving milk or by giving some liquid, but in a bottle. And what we're seeing is that water seems to be the main culprit. So by about, I think, hold on, I'm just going to my notes, about 11 weeks, by 11 weeks, so kind of like 2.5 months, 50% of all the infants in our sample had been already given water. So it's a very young age already that at least half are already kind of like getting water. What we are seeing is that milk consumption, so milk is about almost, I think by the end of the 5th month, you will say that 50% of the children are now receiving milk. Oops. So again, these two, water and kind of like herbal teas, seems to be like the main inclusion into the children's diet other than breast milk that is undermining the exclusive breastfeeding in this region. So just to conclude, I want to say that first, for what we wanted to look, that anthropometric deficit is quite prevalent, and it ranges between 16.5 to 22%, depending on the mix of indicators that you put forward. There is a great overlap between anthropometric deficit, but the overlap seems to be better with weight for age than, for instance, that it is with low MUAC, but we're still playing around with looking at what perhaps criteria, what cutoff for low MUAC might give us a better overlap. Exclusive breastfeeding is low and rapid and falls rapidly with age, and water provision seems to infants seems to be an important target for intervention. And I stop here. Thank you very much.
Thank you very much, Carlos, for your interesting presentation. And I hope we have got enough insights with regard to what's going on in this age group. So saying this, third presentation will be about the Ethiopian DHS analysis, which is to be presented by Basundra from London School of Hygiene and Tropical Medicine again. Thank you.
Hello everyone, my name is Vasundhara. Today I'll be sharing the research project that I did as part of my MSc at London School of Hygiene and Tropical Medicine under Dr. Marco. The title of my project was Weight for Age versus Weight for Length in Identifying At-Risk Infants Under 6 Months in Ethiopia, a secondary analysis of demographic health surveys. The overall aim of the study was to inform the policy debate internationally and in Ethiopia on better anthropometric criteria for programmatic use to identify at-risk infants under 6 months, and to generate evidence to contribute in designing of upcoming cluster RCT in Ethiopia. The specific objectives were to explore the data quality of anthropometric measurements in large survey DHF. Second, to estimate the prevalence of stunting, wasting, and underweight and changes in the prevalences over time. Third, to explore the strength of association between established biologically plausible risk factors of undernutrition with weight for length Z-scores and weight for age Z-scores. Methodology included secondary data analysis of children's record files in DHS 2000, 2005, 2011, and 2016. All infants under 6 months and their mothers were included in the study. The complex design of the surveys were accounted in the analysis. To meet our objective, I looked at the missing data, extreme values, and flagged anthropometric indices to explore quality of the measurements. The prevalence of wasting, underweight, and stunting were estimated after excluding flagged data based on WHO cutoffs. Lastly, bivariable and multivariable logistic regression models were used to explore the associations between established plausible risk factors related to infants, mothers, and households with wasting and underweight. Coming to the results, compared to the weight, length measurements had greater missing values. length-based anthropometric indicators had more flag data than WAZ scores, with an exception in DHS 2005, when WAZ was slightly higher than WLZ scores. Overall, this indicates that even in well-conducted surveys, length-based measurements are of lower quality. This slide shows the prevalence of undernutrition in infants under 6 months. Between 2000 and 2016, the overall rates of wasting, underweight, and stunting declined. On comparing the past two surveys, 2011 and 2016 DHS, an increase in the prevalence of wasting, stunting, and underweight was noted, albeit the changes were insignificant. Approximately 1% of the infants were wasted and stunted concurrently in all 4 surveys, and all the vast infants were underweight. The upcoming slides present association between risk factors and WLZ and WAZ using adjusted models. The analysis here shows that there was no effect of age, sex, and birth order on wasting and underweight. There was a clear gradient of association and plausible trend between birth size and underweight. Current breastfeeding and still breastfeeding was statistically associated with reduced odds of underweight. On the other hand, never breastfed was a risk factor for both wasting and underweight. However, it was not statistically significant. Bottle feeding had surprising direction of association, even though overall it was not significant. Furthermore, there was plausible and strong association of fever and cough in the last 2 weeks with underweight. Odds ratio noted for illnesses was stronger for underweight than wasting. For maternal characteristics, maternal BMI over 25 showed strong and significant protective effect on underweight. Maternal height over 145 centimeters had plausible association with both wasting and underweight. However, it was not statistically significant. There were 2 interesting findings. First, infants had higher odds of being wasted and underweight whose mothers had higher education. Second, marital union had opposite direction of effect on wasting and underweight. Union was found to be a risk factor for wasting in infants. Likewise, type of residence had opposite direction of effect on wasting and underweight. However, it was non-significant. Father's primary education was statistically associated with underweight. In this presentation, I presented only the findings from 2016 survey, as they are the most recent and relevant to the planning of upcoming cluster RCT. But all 4 surveys showed that WAZ had more associations with the risk factors compared to the WLZ. To conclude, length-based anthropometric indicators are problematic due to more missing data, extreme values, producing less reliable WLZ scores. Another disadvantage is that WLZ scores can't be generated for infants with length below 45 centimeters. Lastly, WLZ scores are less strongly associated with known biologically plausible risk factors. WLZ scores, on the other hand, are more reliable, practical in the field setting, and clinically better. Second key message is that infant anthropometric deficit is complex and multifactorial. Anthropometric deficit is not just a diagnosis, but also a symptom to identify underlying problem. Hence, management packages must be comprehensive, with greater focus on family and social involvement, and not just limited to breastfeeding and counseling.
Good. The last presentation for this session will be by Marco Kerak, who is overall PI of this project. He's from London School of Hygiene and Tropical Medicine. He will be speaking about the future RCT we are planning. Then we will have a brief discussion regarding all these presentations. You can go ahead, Marco.
Thank you very much, Malcolm, and thanks again for everybody for joining. And just like we said, so all of these papers all of these projects are just about to be submitted as papers. So do please ask questions, give comments, and the tougher the feedback now, the better, because we want to hear all the hard questions now before we write them up. So in the last bit of this session, I just want to go through our current plans for the actual RCT. And again, comments, questions, much valued, because we do still have a chance to change them. And that's really the aim of these meetings, is to give the wider group of stakeholders a chance to shape input and alert us to things that we should be considering. So it's a cluster randomized trial on the management of small and nutritionally at-risk mothers and infants aged under 6 months. Our overall aim is to generate and disseminate quality evidence that outpatient care using a CMAMI care pathway is effective, safe, and cost-effective, with potential for sustainable scale-up. And again, towards this, big thanks to all our partners, and I particularly love the motto for Jimma University, who are our key partners here. We are in the community, and that's really what we're trying to do. We're trying to be very proactively in the community where the burden of the issues are, where we can make most impact in the long term. So our primary question is, does outpatient care using a MAMI care pathway improve the growth, health, and development of small and nutritionally at-risk infants under 6 months? So that's our main question about growth, health, and development. But we've also got a number of secondary questions. So really important, we're not just thinking about the infant, but we're also seeking to support the mother. So improvements in maternal, especially mental health, maternal well-being, are every bit as important as infant-specific improvements. We're also thinking about the costs and cost effectiveness from both a health system perspective and societal perspective, and are very lucky to have Kidus, who's looking at this as a standalone, again, in the form of a PhD. So a really important part of the overall package. What's the cost and cost effectiveness? And we hope to capture not just the short-term aspects of that, but also long-term. And finally, a work package that Marie McGrath and Ian are leading on is what's the process evaluation? So what can we learn from the process? So if, as we hope, the trial is positive overall, what are the key factors that have led to a positive outcome? But if for any reason we get a negative trial, is there anything that we can learn there? So is it negative just because it doesn't work, or was there something in the implementation that led to that? So process evaluation also really matters. And finally, we're also taking a sample of bloods in a subset of patients and looking for early markers of NCD-related risk. And that ties into a wider study funded by the MRC, the CHANGE study, looking at how early life undernutrition can lead to long-term NCD, non-communicable disease risk. So I'm going to run through a few key features. So it's a cluster randomized trial. And what we're doing, we're identifying health centers and we're matching them. So we've got 2 health centers that are broadly matched on key characteristics like size and location. And then once we have the pair, we'll randomize, so flip a coin, and one of them will be the control, one of them will be the intervention. So we're going to repeat that throughout the district, where pairs of health centers are randomly allocated to either be the intervention or control. And for this, we'll get both population consent, so by the community leaders and community representatives, but also we'll be taking individual consent from patients to enroll. And in order to try and maximize generalizability, we've got 2 study sites. So there's one in Gima, where we plan for approximately 14 versus 14 health centers, and in Deder, so this is a site led by Goal, where we have 8 health centers in total, so it'll be 4 versus 4. I want to run through now our PICO, so our population, our intervention, our control, and our outcomes. And in this, our population is small and nutritionally at-risk infants under 6 months. So this is a term that we're preferring, and there's a long story behind it while we've gone away from the words acute malnutrition. And in short, because it's not an acute problem, we recognize there are risk factors in utero, there are later life risk factors, so it's rarely a purely acute problem. Small, we're defining as those with low birth weight under 2.5 kilos. And they're important because even if they're growing well postnatally, they're still at risk by dint of their low birth weight. The nutritional risk we're defining as low weight for age or low MUAC. So as Carlos has gone through very nicely presenting the rationale for that. We will also be enrolling, but likely not counting in our main sample size, those with low weight for length, those with growth faltering, and those with the reported breastfeeding problems. So in summary, we're trying to capture three main groups of risk. So those who are born small and at risk, and those who have early life risk. So in those first 2 months of life, in early life, and then there's later infancy risk. So especially as breastfeeding drops off, as complementary feeding really comes in and infectious disease risks rise associated with that. So that later infancy risk. So small and nutritionally at risk population. The way the intervention is going to work is it's going to be a two-stage. So all infants under 6 months presenting at any healthcare contact, so be that at birth, at neonatal visit, at immunization clinic, at under 5 clinic, at growth monitoring. So it's that population represented in the survey that Carlos has just shown. So all of those will have a rapid screen, which will consist of mid-upper arm circumference, a weight for age, and a question. The most majority of those rapid screen will be fine and won't require any further action, whereas a small number, and we estimate from that early data, just over 10% will be flagged as small and at risk. And they will have a more in-depth assessment using the MAMI care pathway. And that will take place at the nearest community health center by trained staff. And we anticipate predominantly nurses will be doing this. So small and at risk. At this stage, there'll be a very small number who, having gone through a more detailed assessment, will be able to say, actually, it's fine, there's nothing urgent, nothing concerning here. So we'll be able to reassure them. But having been screened positive, most children at this stage will go into our study. And that will be either into standard care, which I'll go through in a minute, or care following the MAMI care pathway. And then both of them will be followed up at 6 months of age, at 12, 18, and 24 following that. So how the MAMI care pathway looks. So this is just one example. So it's a handbook with a number of different pages, a number of sections, but the key things about it are that it's very simple, it's scalable, it's a checklist which has been well tried, well tested in many, many different countries based on IMCI, the Integrated Management of Childhood Illness. So it's a simple checklist format where you've got a list of key signs and symptoms to look for, and then depending on what you find, they're classified into either high risk, severe disease, or into uncomplicated, or low risk, which can be reassured. This is administered predominantly by clinic nurses, and it helps healthcare workers identify what's the main problem, because we've got a group of infants who are small and nutritionally at risk. But in some of those, it might be a breastfeeding issue, and in some, it might be a very, very straightforward breastfeeding issue, like positioning, which can be sorted in 5–10 minutes. In others, it may be a more complex breastfeeding issue to sort. In some infants, it may be infant illness or underlying disability, which is driving the problem. In others, it may be maternal illness or maternal mental health. And in some, it may be a combination of a number of different factors. So what the checklist does, it helps us identify what are the main problems for this particular mother-infant pair sitting in front of us. And then responding to those main problems, there's responsive support, which is targeted at addressing those, and the guideline shows you how to do that. And a key point is that it's predominantly behavioral support. So even if breastfeeding is currently going well, everybody can benefit from breastfeeding support, and that could be general or specific. We're also really wanting to highlight the importance of maternal mental health. And a very simple, scalable, deliverable intervention is maternal relaxation, which has a small but very exciting and rapidly growing evidence base that supporting mums to relax whilst feeding increases the milk supply, decreases cortisol, the stress hormone, and improves infant growth. So that's something we'll be incorporating in. And there may be other things as identified. So, and using the MAMI checklist to guide advice, guide that behavioral support. For other problems which come up, they'll be referred as needed. So if, for example, there's a tongue tie or a problem which needs a surgical intervention or needs disability support, those infants will be referred. So this is how the checklist looks. So you've got the image, you've got the signs and symptoms of good practice, and then you've got some counselling and support action. So this is what you're aiming for, and this is how to get there. So some very practical advice. The visits are phased intensity. So if an infant is getting better, as we hope will happen, there's a step down process. So initially there'll be weekly visits. So 4 weekly visits, then a fortnightly visit, then a monthly visit. Whereas if things are not going well, if things are getting worse or not proceeding, if the infant's not growing, then we might keep up with weekly visits until such time as they are. And at any point, if referral is needed, that will happen and that will be facilitated. At each visit, we'll assess the anthropometry. So the prime indicator of how things are going is whether or not an infant is growing, putting on weight compared to last time. There'll be a clinical review. We'll be able to address any concerns that the mother has, that the wider family has. And we'll also go through a topic list covering key things in infancy that help development, help support thriving. And that will include topics around feeding, sleeping, and optimizing infant development. And then finally, at 6 months of age, we'll assess how things have been. And we hope that the vast majority of our infants, and especially those in the intervention group, will be growing and will be clinically well, in which case they'll be discharged without the need for further care. There'll be a subgroup who do need ongoing care, and those can be directly referred into CMAM programs for nutritional support or other programs for clinical support. And if there are any defaulters at that time, those will be followed up so we can figure out what's happened to them. So that's the core of the intervention. And then outcomes. So our primary outcome will be the mean weight for age Z-score. So we're looking for changes in that. And we've got a variety of secondary outcomes broadly divided into 3 groups. So we have infant-specific outcomes. So that'll include the other anthropometric measures, MUAC, weight for length changes, height for age changes, and both looking at mean scores and also the percentage who are below a threshold for stunting or wasting. We'll be assessing body composition in a subset. We'll be assessing breastfeeding duration, and then other issues like illness episodes, key behaviors. Development is particularly important as well, though that really in the early months, there's only so much we can learn from differences in development because there's lots of normal variation. So it's especially development at age 24 months, which we're keen to find out about. And again, a subset will have bloods taken looking at lab biomarkers for non-communicable disease. And secondly, maternal specific. So we've said that maternal outcomes are every bit as important as infant specific outcomes. And we'll be using standardized, well-tried, well-tested checklists to look at maternal mental health and maternal perceptions of social support, because I think that's really key, that if a mum feels supported, then she in turn is much better positioned to adequately care for her infant. And finally, economic and process outcomes, which we'll detail in due course. And so all of those, our main outcome will be at 6 months. And then we will also follow up at 6 monthly intervals. And finally, at 24 months of age, to try and look for any long-term impact of this intervention. Our control group will have standard care. So those who have low weight for length, less than -3, be referred to inpatient care for treatment, and they will get transport money to get to the hospital to make sure their access is not an issue. They will get basic nutrition and feeding advice and referral for any other problems that are needed. Those with other anthropometric criteria, for example, those who have a low MUAC or a low weight for age, but are not are not eligible for inpatient care. So they will all get basic nutrition and feeding advice, and again, referral for other problems. And everybody in that group will get full review at 6 months of age. So again, that's a key entry point where they can be linked to other programs if needed at that stage. So thank you very much. So we'd very much value your questions and comments on this, and this is building on the slide that Marie showed. MAMI is really about building bridges between programs, between different things that in the past I think too often have been separated. So programs looking to support infants versus those supporting mothers, those linking community versus healthcare workers, those linking developmental and humanitarian settings. So it's about building bridges, and it's about getting research into policy and practice. And we very much value your ideas, your advice, your questions to help us do that. Thank you very much. Malcolm, we're back to you. Thank you.
Thank you, Marco, for taking us through the PICO. And now we have some 5 minutes to have some quick reflections, questions, comments, suggestions from the participants before we go and break into small group for a few more minutes. So please, those of you who have questions, comments, and suggestions, you can raise your hand so that we can give you the chance to forward your questions and comments. In the meantime, Marco, I think you have one comment in the chat box, so probably if you want to reflect on that.
Which one's that?
From Lucy. Feedback on analysis of mortality overlap for, okay, I think this is not for you.
Is this for Carlos?
Yeah, this is probably for Carlos or for Vasu. Yeah, anyone can reflect on this one in the meantime while we are looking for more questions and comments.
Yeah, so Millicent, it's a very good question. We don't have mortality data in any of these data sets. I think that's, clearly our program, and one of the key aims with MAMI overall is it's about survive and thrive, and there's a really important child survival agenda here. Fortunately, infant mortality is low in Ethiopia, so we just don't have the power to look at any mortality effects. But we do plausibly believe that by reducing morbidity, which we can look at, by improving growth and development, which we can look at, there is also a benefit of mortality. But I think the exciting thing is we're moving towards not just mortality being relevant, but also about helping infants thrive and develop. And I think just remembering as well that it's not just about short-term mortality, but there's increasing evidence that optimal infant growth, so growth that is not too slow, but equally, I think too rapid infant growth can also lead to long-term NCD risks. So that can increase mortality later on in life in adulthood. So that's something we hope will be captured as well as we can in the economic evaluation, that long-term effect. But yeah, we won't have the power to look at mortality in the studies now. So Carlos, so what if you can say something else about that in your work for non-breastfed and non-breastfed?
Yeah, so I mean, we don't have that data present in the data that we are collecting, because I mean, it's very difficult, as Marco said, to have that mortality data. However, for the RCT, we might be able to explore some of that. But I feel like, as Marco has pointed out, mortality is so low that we might not have enough resolution to be able to separate, to be able to adequately assess the potential association between mortality in being breastfed and non-breastfed a child. I've been seeing a lot of other questions with regard also to anthropometrics. We haven't yet looked at the Cormick index. The Cormick index at this very early age. So again, this is something that you need to keep in mind when we're looking into infants. Infants under 6 months, we are going into the spectrum of the smaller babies because they are just recently born. And we are also focusing on those who are young, those who might be smaller. So you need to think in terms of the signal to noise ratio that little variations might do, because we have a smaller measurement. Any tiny variability would just inflate kind of like noise. Cormick index is one of those. So Cormick index at this very early age is something that we will need a really big sample to be able to disentangle how much Cormick index might be affecting relationships between different indicators and potentially the overlap. So I don't think we have that data. Over to you, Malcolm.
Thank you, Marco and Carlos, for reflecting on the raised points. I don't see any more question coming, even if there are few more comments. Again, I think we can have a look at this in the meantime, and we can also reflect back on them during our plenary discussion later on. So I think now we are going to end this session, and we will be breaking into small groups for some 15 minutes where we can have small group discussion. And we will automatically generate this small group formation. So don't sign a log out or don't close this link. It will automatically appear, and then in exactly 15 minutes, we will automatically be back to this large group discussion. Probably, Marie, if you have any message to pass before concluding.
Yeah, thank you, Malcolm. And just to say, we're going to break out for a little coffee break. So maybe if you just grab your coffees and come back to the groups, and you can have a gentle discussion together and have a bit of chit chat. We can't be here all together face to face. So as Marco reflected yesterday, it's like the little coffee queue, and we have a chance just to chat with each other.
Welcome all. Welcome back from the break. So we will be having a couple of presentations in the coming 20 minutes again, after which we will have a plenary discussion and feedback session. So first presenter for this session will be Mubarak Abarra from Jimma University, who will be speaking on policy guidelines and MAMI in Ethiopia. Mubarak, you can start. You're gonna start, Mubarak. Mubarak, you are on mute mode. So
yeah, I'm so sorry.
Yeah.
I was speaking while I'm on mute. Welcome back, everyone. My presentation is on the link between research policy and guidelines, because we expect every research outcome to complement the health service policies, guidelines, and we expect these policies and guidelines to be implemented across the healthcare system to provide healthcare service to the wider community. So we tried to review and explore available existing health policies and guidelines in Ethiopia. And I will have a say just for a couple of minutes. So as I have said, research should support and complement policies and guidelines, and using these policies and guidelines in the healthcare system, we improve and maximize healthcare output, so that we have to make sure that research is in line with policies and guidelines, so that the intake and consumption of research finding will be much higher. So we have tried to review available relevant guidelines, and this includes the National Guideline for Management of Acute Malnutrition. This is revised just a year ago, so it is on use this time. We do have the National OTP Guidelines, National Nutrition Program, Adolescent, Maternal, Infant, and Young Child Nutrition Guidelines. And we do have also National Strategy for Newborn and Child Survival. These all are implemented under the National Ministry of Health through hospitals, health centers, and health posts. When we see the national nutrition policies and guidelines, they all focus on early initiation of breastfeeding, exclusive breastfeeding, and feeding during difficult circumstances, and feeding in the context of HIV/AIDS, and also how to feed young infants in the condition of emergency situations, and also how to feed low birth weight infants. So this is the focus of the guidelines. However, they all have less emphasis how to deal and feed young infants, especially less than 6 months of age. And when we explore these guidelines, they all have lack of evidences how to deal and work for young infants in the country. We do have also mental health policies and guidelines in the country. We do have the old one, and this is under revision now. So the focus of this national mental health policies and strategies is to help improve the mental health and well-being of all peoples in the country. And it also gives emphasis for children and adolescents. However, still there is a gap or gray area how to interlink service for maternal and child in relation with nutrition, API, and other maternal and child healthcare service. So evidence is still required to find out effective way of integrating the mental health service with other nutrition and healthcare service in the country. We do have also early child care and development policies and also strategic document for 10 years. These policies and guidelines clearly emphasize about the nutritional need of infant and also the fetus starting from pregnancy. It focuses on stimulation since pregnancy through childhood, safety and security to the mothers as well as to the infant, maternal well-being and responsive care since pregnancy throughout childhood is a focus of policies related to child development. However, still, as I said, there is lack of evidence nationally as well as internationally about effective way of integrating this service with other healthcare service and nutrition related service so far. In summary, we can say there are plenty of relevant policies and guidelines in the country. They almost all have some gaps regarding how to deal and work with a young infant in the country. So the current study will definitely provide and fill some of the gaps that we are observing now about management and well-being and growth development of this young infant in the country. This is almost what we have for now. Thank you, everyone.
Thank you, Mubarak, for your precise presentation. Last presenter will be Rose Copper from SDG2 Advocacy Hub. She will be presenting what she has done with regard to communications and the stakeholders mapping. You can start, Rose.
Hi, I'm Rosie. I am the Policy and Campaigning Officer with a focus on nutrition for the SDG2 Advocacy Hub. Can you see my slides okay?
Yes, it's visible.
Perfect. Okay, so just a slight bit of background. The SDG2 Advocacy Hub is a body that works to align global advocacy and campaigning around food security, nutrition, and sustainable agriculture across UN agencies, civil society, and private sector. With this background, we were brought in to kind of support the comms side of the upcoming RCT pilot with specifically 3 aims: to identify and assess how the research team should be communicating with various stakeholders in the MAMI work, but also to gather available comms materials in any and all of the MAMI related areas that future comm efforts can utilize, but also build off of. This work was supposed to happen in country, but due to COVID, we've done this work at a distance, and this has somewhat changed and limited how this work could be carried out. So in the first stage, we drew on attendee lists from your October stakeholder meetings, great literature on maternal and infant health in Ethiopia, among other frameworks, to try to map out key stakeholders from the community health worker level all the way up to large NGOs and UJ agencies who are working in or have an interest in and around the MAMI space, with a focus specifically on Ethiopia and coming from a communications angle. The list on the slide, the list that we've compiled is a bit longer than the list on the slide, but this helps to show the variety of stakeholders that we've captured in this work. This is in no way a comprehensive document and requires constant updating, but can kind of act as a starting point when the MAMI team kicks off the communication work. The next stage of this process, we worked to assess how the MAMI team should be engaging and communicating with these stakeholders using the stakeholder matrix, that assesses stakeholders based on power and interest. By power, we define this as actors with the ability to influence the core structure and activities of the program. And by interest, we mean actors for whom the MAMI work is directly relevant. So with this matrix, we were able to distinguish between those who we need to keep fully engaged with close communications, those to satisfy and keeping informed with regular communications, and those to monitor with occasional updates. Patients, for example, would have low power but high interest in this work. When we started this assessment, we saw a need to account for two different timeframes: the short term, which is the implementation stage, and the longer term with the possible scale up of the CMAMI tool in Ethiopia. And in these two different timeframes, the stakeholders' power and interest can change. We like to emphasize that all stakeholders are important, but effective communications requires a nuanced approach that accounts for where specific stakeholders should be engaged at different stages of the process in terms of frequency and intensity of these communications. We'd love your input in this, in both the stakeholder mapping document, but also this matrix to fine tune, but also add in other organizations or actors, stakeholders that we may have missed in this process. And then lastly, we identified and collated communication materials for MAMI related areas, going from growth monitoring to the role of positive fathering to infant and young child feeding from the identified stakeholders. This exercise helps to understand who is talking about what and to whom, kind of creating a picture of the ongoing communication efforts in the MAMI related fields, specifically in Ethiopia, as much as we can, but also kind of in the wider MAMI conversation. This exercise was embarked on because to help MAMI to avoid the duplication of existing resources and instead distribute and reinforce existing messages by stakeholders who are already communicating about these interrelated fields, as well as identify gaps in communication that MAMI can seek to address. Big thanks to the many stakeholders who have shared into this work. Again, we see this as an ever-growing collation of resources, and please, we'd be really happy for any input here. Also, just to close, big thanks to the Gima University colleagues, Malcolm and Mubarak, as well as our Goal colleagues, Adel Hakim, as well as Marie and Marco for your input and guiding in this work. Thank you.
Thank you, Rosie. Now I think we are done with our presentations. We will have some 30 minutes for discussion, and Mubarak will be chairing this session. You can start, Mubarak.
Thank you everyone for your nice and brief presentation and summary of what has been done so far, and also a very nice introductory lesson from Marco about the future plan on the RCT. So we have all these summaries and presentations in mind. We do have all the participants from Regional Health Bureau, from the Ministry of Health, and from various organizations like UNICEF, Save the Children, and the like. So we are very much keen to have your opinion, your support, and your feedback, comment about the way forward, especially any kind of comment is very much appreciated. we are also looking about the opportunities and the strengths of this work, the way forward, and also what are the possible challenges and threats and to implement this project very effectively. So feel free to share us your opinion, your feedback. Who would like to start sharing experiences, concerns? Millie, I have the name Millie, Meron, and also Claire. You can share us your concern. Ashaber.
And indeed, any opportunities that you see working within your work streams, your area of interest and work where you are. The smallest little inroads or opportunities are hugely valuable. So really or even if it's just an experience that you want to share about working with infants under 6 months or their mothers, or what you've observed, any insights at all are give us such rich learning. So please don't hesitate to share.
Yeah.
Yeah, because I think we're particularly interested how others have found this group in their programs, in their projects, and your current experiences, and how we might shape the wider MAMI work to support you and your organization. So how can we make things help you? Over.
Okay, so Millicent here. Can I?
Please, welcome.
I think I really love the MAMI project. I think I've seen it go through phases. It's not an experience, but it's just for learning. Now I see that it's still at study stages, but more and more the partners that we work with are getting interest to roll it out. Some have already begun to roll it out. Action Against Hunger, Concern Worldwide, we have ASDEPO. I'm talking about Gambela, where I am, International Medical Corps. So just to maybe request that we need to have maybe better simulations, orientation, guidances, so that we don't have everybody doing everything, and then at the end of the day, we distort the whole process and the intentions. Yet, I think it's a good thing that we are having interest from the international partners that we work with. So at what level, or in terms of management of the whole of that outcome, or using that information that is being collected to inform the great work that is already being done. So I think it's just a concern that it's already like being done, but then I think there could be missed opportunities in terms of accuracy, precision, flow of processes, and things like that in Gambela region, yeah, to be specific.
Thank you very much, Emily. Ashaber, Ayenau, Semenash, Meron, you can also share us your concern, question, or any ideas.
And maybe just a word, Millicent. I think we have Ritu here on the line from Goal, who's the MAMI advisor with Goal, and I know Goal are a partner in this research, but also relate independently, but very much synergistically have been working in Gambella, and indeed have been in liaison with ACF to try as well to, as you say, coordinate and have that cross-learning and shared processes. And Rita, I don't know whether there's anything you could speak to regarding what Millicent was sharing about that sort of cross-agency collaboration as people roll out.
Yeah, just one thing to add. I think because of COVID-19, I could not travel. Ideally, I was supposed to travel 4 times a year to Gambella. I think in January, I would be able to travel. So Millicent, if you can see if there is an opportunity, I can meet everybody. I mean, all the partners there. And if they have any questions, we can have a brief meeting there, more on MAMI research and implementation. I mean, goals experience of implementing it's during pilot stage since 2015, 16. And now like we have I think 2 years data. Over.
Thank you, Ritu. Do we have Claire in this meeting? We appreciate
Yes, hello.
Yeah, please.
Thank you for the good presentations. Most of my work is in infant and young child feeding, so I'm not very familiar with the MAMI guidelines. So though I have worked on the CMAM, what I would like to highlight is the stakeholders elevating the role of relactation in the management of malnourished children below 6 months. The CMAM programs I have worked in, we never used to get a lot of children below 6 months, but the few that we worked on, most of the time we relied on the therapeutic milk that the women find in the stabilization centers. So they tend to lose confidence. They may not understand that they have a part to play in preventing malnutrition or in avoiding a relapse. So sometimes the staff may not pay a lot of attention on relactation. I think that this is what will help the women and children understand that the main reason the child found themselves in the stabilization center, mainly it was because there was a challenge in breastfeeding. So that counseling and building the mother's confidence to be able to produce enough milk, I find it very weak. Rather, the staff emphasize the therapeutic feed and then the medicines and then anything else, but then the relactation bit is very weak. So this is what I don't know, this has been my concern, and it's what I would like to see being scaled up in the MAMI guidelines.
Thank you so much, Claire. Comment well taken. Yeno, can you share us your concern, your say?
I cannot hear him, although it's he's unmuted. And now?
Yeno, can you hear us? Okay, maybe Ashabir and also Semenish, if you are around, can you share us some thoughts?
Hi, this is Semenish from USAID. Can you hear me?
Yes, we are hearing you, Semenish. Please,
Yeah,
welcome.
earlier on the tea break, we were talking with Marco about my concern. So already my concern is answered. Just to share my opinion, I'm new for MAMI, so I appreciate the team like for your initiation. So just my concern is like are the Ministry of Health from like regional, and are they engaged in the process? Because we know, you know, like whenever a new approach is engaged, they like it's normal to challenge, but if they are engaged throughout the process, it will be easy, you know, to scale it up to all region. So my only concern is that one. Over. Thank you.
Thank you so much, Simenash. Just to reflect on that, yes, it is really very much important and a mandatory issue to involve the local administrations, especially starting from the Ministry of Health down to the regional health office and even to the zonal health department. So we have organized a consultative meeting, stakeholder engagement meeting last year in October. So everyone has been invited and shared their opinions and feedbacks. So your concern is very much relevant. Thank you.
Maybe to add another, sorry?
Okay, please, then we will proceed to Ashaber. Please continue, Simenash.
Yeah, I know, like you have been start this approach in Bangladesh and other country. Is there any experience or maybe challenge that you can share to us, you know, during implementation, because the approaches align with the existing system, right? With the health facilities, screening and etc. So like, what is like how did they take it, or maybe they challenge that you can share with us?
So I will give opportunity for Marco or Carlos just after the next speaker to reflect on experiences in Bangladesh and other countries.
Yeah, so maybe if I could just give some key background. So when we first started this, one of the very striking things, and that was in 2008. So the first MAMI report was in 2010. So there were two things then. I think one, people didn't recognize that there was a problem. There was an assumption that because infants were mainly breastfed, that malnutrition, that undernutrition would be very rare in this age group. And that clearly isn't going to be the case, because we've known for a long time in pretty much all countries to a greater or lesser extent, breastfeeding is suboptimal. And even when it is good, there are always a variety of reasons why it's not just about feeding. There are other underlying clinical reasons and other reasons why infants may have problems. But the other thing back when we started was that all guidelines were just focused on inpatient care. So if an infant was identified, they had to go to inpatient care, and that was the only guideline that existed. And so it became an issue of don't look, don't see, because the stakes of identifying an infant who was small or at risk were quite high. And in fact, policy-wise, progress was made pretty quickly, because way back in 2013, WHO recognized that there was a group who, I think Millicent, you were saying there was a group who actually, if you dealt with them in the community at an earlier stage, then you wouldn't need the inpatient care. And so back in 2013, WHO recognized that in their severe malnutrition guidelines, that outpatient care was fine for uncomplicated, so that's clinically stable small infants. But that's been quite slow to be developed to roll out to national levels. And so the MAMI programs that have been led by NGOs, by programs, by at small scale. So a good analogy is the early days of CMAM, when people are very open to the idea, but actually just need more details. And that's the phase we're in at the moment. And we were saying in our coffee break that what we're doing at the moment is more formal research. So in terms of a formal randomized trial, so that's definitely needed. And we've heard that many, many times, that people want to see that level of evidence. But equally, there's a big need for organizations, for districts, for example, to just try things out using guidelines that already exist, and to get some operational evidence, operational feedback, because there's nothing really massively new in MAMI. It's all there in existing guidelines, but it's about making the links, about bridging different services. And one way to perhaps think of it is it's like signposting. And the problem now is there's very poor signposting. So problems don't get picked up on until they're very late, very advanced. So MAMI is about identifying them early, and then about helping people direct mother-infant pairs to where the treatment is better. So it doesn't need new skills, it doesn't need new methods, it doesn't need new therapeutics, but what it is, it's about bringing everything together, building bridges, it's about packaging things and putting it all together in a simple, doable, scalable, sustainable way. So it's about bringing together, and that's what we're trying to do. And yeah, do have a look at the website and get in touch afterwards, because one thing that we're doing at the moment is we're updating the MAMI care pathway. So that actual checklist that people can use, can try out. So we'd value your feedback on that, and also be great for others to try that out.
And maybe just to quickly just add, this is also like in my opening slides where I talked about the MAMI Global Network. We're very much about leveraging and learning across contexts and settings, and indeed the experiences in Bangladesh and in Ethiopia and in other contexts have informed what we are now co-creating in Ethiopia as this research. We're very much about encouraging sharing and learning across contexts and synergies. And indeed, we have Eleanor Rogers, who's the new MAMI Global Network Coordinator, on the call today. So we're very much about capturing that. And this is why we really want to strengthen the links with Ethiopia into the MAMI Global Network. And we'll touch on this a bit in some of our closing remarks in terms of way forward and opportunities.
Yeah, so do please write and get in contact, because one thing that we're planning for some time in the new year is a MAMI network meeting, which Eleanor will be leading on. It'd be great to hear more of your experiences for those colleagues on the call today to present what their priorities are to attend that meeting. So again, because of COVID, it'll be remote this year, but at least that makes travel easy. But we'd like to build up, as well as the international network, also local chapters, because we know that there's lots going on locally there in Ethiopia, which is very relevant. And it'd be great to have a local network meeting and sharing what you do there, so that others can learn from it. So in the same way as people learned from Ethiopia's very early experience of CMAM, and that scaled up to now be just standard of care. That's just what you do. We hope that one day in the not too distant future, MAMI will be the same, where the early work in Ethiopia will be picked up on by others and scaled.
Thank you so much, Marco. Let me give the chance to Ashaber to reflect your thoughts.
I think Ashaber is no longer here.
Yeah, Ayero is just over.
Ashaber was starting to speak earlier. Ashaber, are you there? Okay,
hello.
Ayeno.
Hello.
Hello.
Are you hearing me?
Yes, we are hearing you, Ayeno.
Okay. First of all, I would like to say thank you all the researchers, stakeholders, and all the presenters who are involved in this stakeholder meeting. Having said that, I have one suggestions regarding our CMAMI package of care for future implementation, especially in Ethiopia. I have one question. Can we assess the duration of time, especially to compare the standard treatment protocol that is already implemented in the different health centers of Ethiopia with the new treatment protocols that will be implemented as cluster randomized trial? Can we compare the total duration of time to treat the malnourished infants by comparing with that of the standard treatment protocol with the current CMAMI package of care, so that we can analyze and assess the cost effectiveness of CMAMI package of terms of time. Over.
Thank you so much, Ayeno, for sharing your thought. I think it is very exciting idea what you said. So far we haven't considered to compare in line with time to recover between the two intervention protocols. That can be one idea to incorporate into the existing objectives. I think we can discuss more in detail about this. Thank you for sharing your thought. I think let me give back the stage to Mari or Malkamu so that we can proceed to the next session. Thank you everyone for sharing your concern, your comment, your feedback about this project work. Much appreciated.
Thank you, Mubarak. And just to say, thank you so much. This has been such helpful feedback, and I feel as if we've just started the conversation. So please just do see this as the start of a conversation with us. And towards the end, we'll share you contact details. So please keep your suggestions coming to us. And we've noted everything in the chat box as well. So we'll be taking everything all very seriously, and we may follow up with you directly for some more information and clarifications. So that's wonderful to see this. I'm just going to share a few key opportunities or activities I just wanted to share more broadly with you. The first regarding WHO guidelines on management of wasting. WHO is undertaking a large update of their global normative guidelines on management of wasting, and this process has now started. With a view to having updated guidelines by the end of next year or beginning of 2022. So recently they commissioned 4 scoping reviews to inform a scoping guideline meeting that happened just a week ago, where the guideline development group got together to have a look at the scoped evidence and to identify areas, priority research questions that could then be addressed in a series of systematic reviews and other forms of evidence compilation, which WHO will commission in the new year. And these will then take place through the first 6 months or so, and mid to maybe 3rd quarter of next year, they will then have a large guideline development meeting to review this and come up with key recommendations. Marco on the line here is on that guideline development group, as well as representatives from regional countries and experts. One of those reviews was on growth failure in infants under 6 months of age, which captures the exact group that we're looking at. And DNN, in collaboration with the London School of Hygiene and Tropical Medicine and other members of the MAMI Global Network, undertook the scoping review that was presented at this WHO meeting last week, and has helped inform the scope of what will be the updated management of wasting guidelines. So I just wanted to highlight it as a key initiative happening at global level, but that which we are engaged with, and will be leveraging the evidence and the experiences that come out of Ethiopia and many others to inform that process. And indeed, we'll be including updates to all on that, because we very much want to walk the walk when it comes to putting national agendas and priorities on the table of global efforts initiatives, which comes to policy guidance as well as sharing international practice. So that's a critical opportunity that we're working with many on. And the other thing I wanted just to flag with you, and I will share my screen, is I mentioned in my opening conversation that we are updating our MAMI vision. So Eleanor Rogers, as I said, who's the MAMI Global Network Coordinator located at ENN, is working on this with us. And so we are looking to update both the vision for the approach, the initiative, of management of at-risk mothers and infants under 6 months, as well as the vision and mission of the MAMI Global Network itself. So we have a number of vision options on the table, which I'm just sharing with you now to have a little look at them. So there's certainly framed in slightly different ways. They all have the essence is the same, but there's different ways of saying it can resonate with different groups, different people. And it's most important that it resonates for those of you working on the ground, frontline in countries. So in the new year, we'll be sharing a little short consultation, SurveyMonkey, to get feedback from all, and we will certainly be including you in that. So I'm just wanted to highlight it as initiatives so that when it comes round, we'd really very much welcome your feedback. And we'll also share the vision and mission options for the wider network as well. So that's everything from me, and I will hand over now to Malcolm, who's going to share some opportunities stemming from a recent meeting that we presented, the Ethiopian Nutrition Leaders Network, and some of the opportunities and avenues that we're exploring in that regard. Over to you, Malcolm.
Thank you, Marie, for giving us insights with regard to what's going on globally in relation to MAMI. And in the country as well, there are several platforms which we can use as opportunities to learn from and to share our experience with regard to MAMI, and in order to disseminate what we have found, among which the Ethiopian Nutrition Leaders Network is one, which has been established, I think, recently, and we have learned that they are doing lots of things with having regular meetings and sharing what one organization or group did with another, so that one can learn from the other. So we are also planning to get networked with this network so that we can learn from what others have done, and we can also pass key messages that we have learned from our activities, so that we can get updated informations and also disseminate our findings as early as possible. One of our investigators, senior investigators, whom we didn't have in this meeting, is part of this network, who is Samuel Gima, and he is also closely working with the Ethiopia Ministry of Health, and his other team members are also working with different organizations, and particularly the Ministry of Health. So we will be utilizing this as an opportunity as well, so that we can maximize our effort in carrying out our activities. Probably Alam Sagad could add a few more things on this, and he will also wrap up the presentations and our discussions this afternoon. So time is for you, Alam Sagad.
Is Alan Segert still there? Connection.
I think he has dropped. So probably, Marie, back to you so that you can wrap up and probably finalize it. Marco can also add a few final things before we conclude.
Absolutely. Well, I'll say a few words and then I will hand over to Marco. A huge thanks to you all for participating. As we said at the outset, we would love to be face to face, but this is the next best thing, and actually has been a great opportunity to connect with you, and we look forward to more initiatives just like this. I'd like to say a big thank you to the Elena Crook Foundation, who are supporting this research in Ethiopia, and indeed a lot of our work on the MAMI Global Network together with Irish Aid, who are providing support to INN in this regard. And indeed Elena Crook Foundation have proven to be a very sensitive and flexible funder with a long-term vision towards scale, which very much resonates with what is a priority in Ethiopia and what's a priority for our research. So this really has enabled a very facilitatory and open and creative partnership, and it has allowed us to also react to the situation in COVID-19 and adapt as we need. So we very much look forward to this continued conversation with you all, and please do share the insights you have with us and also with your colleagues. And we'll be sharing links to our website and information and the recordings. And so please, again, do share with your colleagues so that we can continue to spread the word and get your engagement. Marco, I'll hand over to you now for any final reflections from yourself.
I think you said that's a very nice summary already, but so I just want to end by saying big thank you to everybody who's joined today, and those people who we've met, so new friends, and also again great to be in touch with others who we've been in contact with early in the process. So thanks to you all, thanks to the team who presented today, to everybody who presented, and also to all the field workers and the project staff who did all the important frontline work, and to the patients who were measured and assessed, and all those who responded to the questionnaire. And yes, indeed to Elena, Crook, who are really understanding, very generous with their time, with their resources, funding for enabling all of this. And really just want to wish everybody on the call a lovely Christmas break, all the best for 2021. So let's hope that we've got 2020 well and truly behind us. So, and it's been great to get over all the glitches, really thanks to the wonderful work of everybody there in Ethiopia to have made a huge amount, even in such very difficult circumstances. We hope and pray that 2021 will be a lot better, a lot more fruitful, and I'm really looking forward to the next phase of the project and looking forward to working with everybody on the team, but also the wider group, to make things as high impact as possible and to scale things up and take things to the next level. So, wish everybody a very happy Christmas season and New Year, and thank you all again.
Thank you.
Thank you very much, everyone.